the field is very competitive now in terms of research alternatives for patients who come off ruxolitinib, as well as commercial alternatives. So it has to be noted that fedratinib is a FDA-approved therapy with a broad open label that is it's greater than 50,000 with the diagnosis of myelofibrosis. And although it doesn't stipulate whether it needs to be first or second line, if you look at the Jakarta-2 study, which was a phase 2 study that compared, didn't compare really, it evaluated fedratinib as a second-line option for patients who had failed ruxolitinib. That was an effective agent with response rates with splenomegaly, for example, of 30%. So you can clearly get responses and salvage responses as it relates to spleen and symptom burden with fedratinib, understanding it is also a FLT3 inhibitor, so there's some GI toxicity, so one needs to be aware of that and proactively manage that aspect. But it gives patients in the community, I think importantly, another JAK inhibitor option. Beyond that, there's a lot of interesting work that's informed by laboratory studies such as inhibition. So the combination of, or adding a drug like CPI 0610, which is an oral pan-BET inhibitor to ruxolitinib in patients who are having a suboptimal response, failing response, and then drugs like navitoclax, which is a BCL2 inhibitor. So there are many things that in the pipeline that are developed to try to either salvage responses, either as a single agent or in combination, both looking at spleen symptom, quality of life, and as I said before, hopefully increasingly overall survival.